Good afternoon, everyone, and welcome to a discussion today focused on the nursing workforce issues here in the United States. I'm Bill Hoagland. I'm a Senior Vice President here at the Bipartisan Policy Center, and I have the pleasure of working with our health and economic teams on those issues that confront policymakers today. To us, bipartisanship is not an oxymoron. We truly believe that long-term sustainable solutions to the challenges we face are achieved when they are done with bipartisan support. We know it's a challenge today, given the hyperpolarized environment we live in, but we will continue to try to achieve those goals. It seems appropriate that we would hold this discussion during National Nurses Week, which began last Friday and will end on Florence Nightingale's 202nd birthday this Thursday. And coincidentally, but maybe not so coincidentally, this is also National Hospital Week. So I doubt that anybody would disagree that it takes nurses to make hospitals and our healthcare system work, period. So today we will be joined by a group of experts to discuss the interrelationships of nurses and hospitals and the nursing workforce. From the latest 2019 census figures, there were nearly 2.4 million registered nurses. The vast majority of them, 1.9 million, worked in hospitals. But there were also nearly 500,000 licensed practical and vocational nurses, nurse anesthetists, nurse midwives, and nurse practitioners. Last Friday, the Labor Department reported that we were back to almost pre-pandemic employment levels in a number of areas: manufacturing, transportation, professional, financial, and business services, and even retail trade. But the healthcare employment remained nearly 250,000 below pre-pandemic levels. Further, even if we were to get back to the pre-pandemic healthcare worker levels, we know that nursing shortages existed even before the pandemic arrived. So as hospitals grapple with this, with the current shortfall, I note a front page article in the Wall Street Journal yesterday that pointed out that two major hospital systems are proposing to increase nurses' salaries and are asking the health plans to pay for them, pay the hospitals to more than offset the higher nurses' cost. Of course, on the other side of the equation, we know that insurers and employer groups are rejecting these requests, saying that the prices hospitals can absorb these higher labor costs. So I expect with the overall inflation rate out there at a 40-year high, healthcare costs will become an even more important issue going into fall and early into the next 118th Congress. We know from our first event that we had on this subject earlier this year that salaries are not the only factor creating the shortfall. Retirement of the baby boom nursing population and the challenging work environment brought on by COVID are just being two of them. So today we will hear from this group of distinguished and knowledgeable panelists addressing not only the current nursing shortfall, but longer term approaches that are needed from federal policies to support our nursing schools. It is our hope that out of today's discussions that we can find a consensus on recommendations that we can put forth here at the Bipartisan Policy Center later this year. So before turning us over to the moderator of our panel, a nurse herself, Sheila Burke, and an advisor here to the health team at BPC, I want to thank the Federation of American Hospitals for their support of this event and our ongoing work in this area. And I ask now that the president of the American Hospital Association, Chip Kahn, for any comments he would like to make at the outset. Chip, it's over to you.
Thank you so much, Bill. And I want to thank the Bipartisan Policy Center for the leadership in addressing this nursing issue. And we do appreciate the opportunity at the Federation of American Hospitals to support this important effort. COVID-19 has taken its toll on all of us, on all Americans, but particularly important aspects of our healthcare system. In a sense, our system is suffering from long COVID. This is particularly the case with our nursing workforce, and why this discussion is so important today. where hero fatigue has clearly set in with nurses, with a number of ramifications, including contributing to the current nursing shortage that you refer to. As you said, nursing is the keystone of hospital care. Today's session, as Bill outlined, will build on the one we had a few weeks ago. Hopefully, we will begin to explore solutions, short and long term, as well as the factors which make turning this problem around so challenging. So with this challenge before us, I pass the baton to Sheila.
Actually, I'm going to pass the baton to one of our panelists. We have a terrific group of individuals talking with us today. As Chip indicated, we began this conversation in March, and we are continuing today. And the focus in particular today is the question of essentially how we get the pipeline going. What do we know about the number of nurses leaving the practice? What do we know about the number of nurses essentially entering school and graduating? What can schools tell us about how we're preparing nurses to essentially go into practice? So we have a wonderful group of individuals who are able to talk with us both about the experience in schools and specifically about what the federal government can do to help us address the workforce issue going forward. But first, we're going to begin with Polly Pittman, who's currently a professor of workforce equity at George Washington University. Polly has spent a great many years looking at the question of workforce, looking at essentially the initiatives at the federal level and what we know about what's happening on the ground. So let me turn it over to Polly for some early comments, and then we'll turn to the panel discussion. Polly?
Thank you, Sheila, and thank you to the Bipartisan Policy Center for inviting me to participate in this webinar. We can bring up the slides, Greg, if you would. So, assuming you all can see them, I'll be talking about sort of a snapshot of what we see with the nursing workforce now and some policy options that are being talked about, some of which are old and some of which are new at the federal level. So I just wanted to give a sort of quantitative picture of what's happening right now. So on the one hand, we have, as Sheila mentioned, an issue with the pipeline that people have focused a lot on. So we have about 185,000 nurses graduating every year, RNs. That's actually pretty close to what the Bureau of Labor Statistics projects we'll need annually between now and 2030. They project that we will need about 195,000. So we're not far off in terms of the actual bodies that we're graduating. There are constraints on the pipeline. If we want to continue to grow it, we can. There are a lot of qualified applicants to nursing schools that are turned away, and it would be pretty easy to expand the pipeline if we address some of the constraints. And those are largely around faculty shortages and to some extent clinical sites and preceptors. So we have policies that we know work in this area. We have somewhat of a problem in this area, but I don't think it's unsurmountable. We have a couple of other things going on, however. So there's not a distribution across the country that is exactly equitable. And it has a lot to do with where nurses want to work and where there's demand for nurses. So the American Association of Colleges of Nurses does a survey of graduates every year. They report that in the West, California, Oregon, Washington, the number of nurses that are getting jobs at graduation is about 60%. So relatively low, suggesting that the market there is still a little bit less tight, shall we say, than in the South, where there is a fully 84% of the graduates have job offers when they graduate. So there's some implications of this that I want us to think about. We know that in the West, we have higher nurse to patient ratios to start with. And there, I think is a suggestion that this softer market could have to do with the fact that more nurses want to be working in the West than in the South, where working conditions are more difficult. We also have an issue of leakage. Once nurses are starting work and in their jobs, they don't always stay. They move around from job to job within the nursing profession. And they also apparently increasingly leave the profession altogether. So we have new BLS data that was reported in Health Affairs a couple of weeks ago that we're down over 100,000 nurses. Most of those nurses who are leaving the profession are nurses that were working in hospitals. And interestingly and surprisingly, it's not the older nurses, but it is the younger nurses, the under 35 years old. This is the first time in 40 years that there has been a decline in the number of nurses in the economy, in the workplace. And it's a real shocker. I know the hospitals were saying this was happening. We now have the numbers to show that indeed it was happening and continues to happen. So apparently we have system level problems that are causing a leakage in the current nursing workforce that need to be addressed as well. So the question is, why do we have this leakage? In my opinion, I think we have kind of a background that we know from labor economics, which is what folks have called the counter-cyclical nature of the nursing labor market. When there is a recession, nurses tend to go back into the market because their husbands, children are losing jobs or having difficulties. Nurses tend to increase their hours or go back into the labor market. When there is full employment, like we have now, nurses tend to cut back on their work hours and may even leave their employment. So we have an underlying counter-cyclical nature that is driving this and that we've seen several times before. Hospitals know how to deal with this counter-cyclical labor market. They use bonuses, wage increases, tuition reimbursement, transition to practice programs, flexible scheduling, daycare, awards, even international recruitment. So these are kind of the traditional toolkit that hospitals have to address the traditional counter-cyclical labor market that we're experiencing. Of course, then we had, in addition, sort of the layering on of the pandemic. We had a lot of stuff happening during the pandemic in terms of the working conditions that were very difficult. And the response has been, on the one hand, a lot of federal money going to help hospitals pay for nurses. That funding is going to end with the end of the emergency, the public health emergency. So that was a temporary measure. Hospitals are stepping up, doing, improving access to mental health and confidential counseling, peer support, mindfulness, and again, a big push for international recruitment. So the question is, is that all that is happening, or is something else happening as well? And if we want to think about policy solutions that are going to really stop the leakage or diminish the leakage, we really need to make sure that we understand the major drivers. So in the work that I've been doing, which is interviewing nurses about their working conditions, and the work that we've been doing under a government grant, a HRSAT grant, to create a National Center for Technical Assistance on burnout, what we're finding is that there is something prior to burnout that is really important, and some have begun to call it moral injury. Wendy Dean and Simon Tabbitt wrote an article in 2018 describing the phenomenon of moral injury. It's largely a concept that comes from the Department of Defense and from the VA, and was applied to soldiers returning home from war who had a form of post-traumatic stress disorder that was specific. And the symptoms are a feeling of guilt and shame and helplessness. But when you back up and understand what's really happening, what people say is that they are feeling betrayed. And it's not just betrayal by the employers, but it's a betrayal by society. It's a betrayal perhaps by colleagues. It's something that has happened that makes people feel as though they can't do their job, they can't do their duty. Something is in direct conflict with their professional code of ethics, their professional code, not just their personal, but their professional code, their duty. And they have a choice of whether to speak up or speak out. And if they don't, they essentially are sort of violating their own professional code. And that's called a transgression. And it leads to this sense of guilt, shame, and helplessness. And it is kind of a prior situation to burnout. There are other drivers of burnout too, but this may be the super highway. So I think it's important to not leave this concept out as we think about the drivers and about the solutions. It's at the level of organizational culture where, for a long time, nurses have been saying that they're not heard, that their concerns about staffing and, workflow, et cetera, are not taken into account to the extent that they wish it would be, largely because there's a business culture that is not accustomed to listening to nurses and their front line kind of concerns. But there are also government policies, some intended, some unintended, that have effects on how work is structured for nurses, and we'll go more into that in a bit. And then lastly, there are societal issues that go way beyond the hospital culture or policies themselves that have to do with issues of power and status and money in our country, of course. And we know that the issue of racism has been very front of mind for everyone, but there's also an issue of trust in institutions and trust in science, of course. And as we know, that's led to a situation in which nurses have been challenged and even harassed by patients and their families. So all of these things are driving moral injury. So when we think about the policies, I think there are a number of policies that we know are effective in terms of the pipeline. We know we can enhance loan repayment under Title VII. We know that a lot of the distribution programs, for example, the National Health Service Corps, the Nurse Corps, is very effective in terms of incentivizing people to go to areas where they're most in need. The programs in particular that fund faculty in those shortage areas are very effective. I think there's some experimentation with the idea of tax incentives for preceptors to increase the number of individual tax incentives for folks who serve as preceptors that have been very effective at the state level. And all of the programs that focus on the transition to practice, in particular for RNs, but also for NPs, have been shown to be very effective. So those, federal support for these kind of classic approaches, I think is tremendously important. But we also need to think about what we can do to help hospitals do what Wendy and Simon call flip the switch, which is basically to begin to really prioritize a focus on frontline workers and what they need. And I think hospitals are not alone in this. There are a lot of reasons why hospitals function the way they do based on the payment policies we have, based on the market forces at play. So some of the ideas that I hear in the policy sphere in Washington that are being talked about these days include the following. There are a number of ideas about better data to incentivize this change in culture. One idea that CEO has been advocating for a while is to have, much like providers have a national provider database where if there's malpractice, they are recorded in a national database. Folks believe that perhaps CEOs should also have that kind of accountability in terms of what their track record has been at hospitals. There's an idea that we need to develop a moral injury survey, kind of like a national sample survey, to take the temperature of this problem across hospitals and other healthcare settings over time. And there's a lot of discussion about the need for better reporting on staffing, not just adjusting for staffing mix. In other words, nurses don't work alone, they work on teams. So having more of another member, of another kind of team member also helps, but also in terms of patient acuity and thinking about issues like how do we average staffing ratios over time. There are regulations that people are talking about. Of course, the idea of guardrails on staffing ratios themselves, moving perhaps away from the state regulations or state laws to thinking about Medicare and how it could be used as a way to encourage, if not oblige, hospitals to meet sort of a minimum staffing ratio. Discussion about the sort of unintended consequence of policies that have pushed technologies and incentivized the technologies when they hadn't really been tested or proven. Some people are talking about the need for an FDA to kind of approve technologies before they're given to frontline workers because it's so disruptive to the workflow and can create such a sense, in this case, of betrayal when they're obliged to use technologies that are not effective. Of course, OSHA and CDC have their workplace occupational standards, and they are rarely kind of implemented forcefully. So those are programs that exist and that could be kind of bolstered. The White House has talked about prohibiting non-compete clauses. This is particularly important for physicians. A lot of the contracts and for international nurses don't allow people to move. And if we believe in free markets, we should believe in allowing people to move across jobs to reward the employers that are offering the best conditions. Worker protections include things like national whistleblower protections, banning mandatory overtime. And then lastly, payment policy is kind of the 800-pound gorilla, and it's been a policy that was the focus of so much of our work over the last 10 to 15 years. And thankfully, it is actually one of the few areas where there's bipartisan agreement that we should be using payment policy to incentivize changes. And we know that there is sort of an unintended consequence of the excess reporting requirements. The frontline workers report that they feel that that's shifted the focus of attention away from patients and to meeting these reporting requirements. So I think that's something that CMS and others will have to think about and review, and advancing payments that are simpler and really focused on whole person care, by which I mean sort of including the social determinants of care, are things that might help alleviate some of the sort of root causes of the moral injury issue. So those are ideas up for debate, up for discussion. Some of them are controversial, some less so, but I look forward to the conversation. So I'll turn it back to you, Sheila.
Great. Thank you so much, Polly. We have, as I indicated, a terrific panel that will help us look at these issues and respond to some of the suggestions that Polly has made. Each of them bring their own experience with either students or in terms of institutions and how they're handling these challenges. I will very quickly introduce them all. They have long resumes and are remarkable individually, but let me quickly get to our conversation. I want to also remind folks to please enter into the chat box any questions that you have, and we will turn to those questions during the course of our conversation. So we want to be sure that we respond to the issues that you have as well. So please enter them and we will get to them as we go through. Let me first introduce Dr. Linda McCauley, who served as the Dean of the Neil Hodgson School of Nursing at Emory University since 2009 and has a long history of working on these issues and has taken Emory, I think, to number 2 in terms of the ranking of schools of nursing and done just a remarkable job. Mark Boat has served as the CEO of Galen College of Nursing, which is located in Kentucky, and he is still celebrating the Kentucky Derby and the remarkable results. His leadership has helped really expand the nursing academic programs at Galen and really learning environments and changing the nature of the way they, in fact, teach and creating lots of innovative pathways for folks to enter the nursing profession, which is one of the challenges. That is the question of how you move from an academic setting to a clinical setting successfully. And finally, Maria Zangardi is the Regional Director in the Human Resources position at Universal Health Services, the Health Resources team, and has served on the Federation of American Hospital Working Group and has been a leading voice in looking at questions of how we essentially deal with the nursing shortage and the challenges that hospitals are in fact facing. So let me very quickly turn to the group. I'm going to ask a couple of questions, and this is meant as a conversation, not as a sort of here's a question, here, let's get an answer. So I encouraged all of them to talk with one another and to respond to the questions as we pose them. Let's begin, if we might, with Galen and Linda and talk about, are you in fact seeing enrollment declines? What are you seeing in terms of the nursing students entering the colleges and universities? Are we experiencing the kind of challenges that Polly has suggested in terms of a decline in the interest in entering the nursing profession? Or if not, what in fact are you seeing and how are you responding to the desire to look at the pipeline? As Polly points out, we know there are questions with faculty, the number of faculty. We know there are questions with placements and essentially finding locations for training. So Linda, let me turn to you first and then to Mark.
Thank you, Sheila, and thanks for a wonderful presentation, Polly. I have to say, from my standpoint, we have not seen any lessening of interest in nursing. And in fact, I often say that COVID, as bad as it was on its impact in the profession of nursing, there are always individuals who choose to run into the fire, who want to be part of the solution. And so our application numbers have not diminished at all. In fact, they've grown almost twofold. But the difference is that not all nursing schools can really accommodate in any way, shape, or form an increase in enrollment. And so what I was able to do at Emory is actually double the number of my faculty so that we could double the number of our students. So we grew from 400 students a decade ago to almost 1,400 students today. I'm not, I don't have to get approval from a state legislature to hire or to have more faculty tracks. I don't have to seek approval or make an argument for how many more faculty lines that I need. Unfortunately, I think the majority of nursing programs are not as free to engage in growth as perhaps as much as I and Mark have been able to do. So Mark, do you want to weigh in on that?
Thank you. I mean, I believe that very similar to Linda's comments that, we aren't seeing any decline in interest in new to practice nursing, those wanting to enter the profession. What I think we are seeing is a slowing of those post-licensure programs across the country in many areas. But the new to nursing pipeline has continued to expand in all the communities that we serve. And our niche is, I think, higher education, especially nursing education in our country, has a great fabric in our country, serving all kinds of different individuals, meeting them where they are. Our niche is a little bit different. We cater to more of the adult learner. The average age of our institution is about 30 years old. So we focus on trying to bring those into the profession who may have missed their sweet spot early on. And, I think to address the shortage, which is very real from our healthcare partners, is it's going to take a collective force in our US to try to address this in many aspects, not just the traditional means of someone just coming right out of high school or just meeting with those learners where they are. So it's going to be a lot of different resources that are going to be brought to bear. And I think highlighted in the presentation, I think that we all face is faculty. Faculty resources. If you ask any dean of nursing in our US, faculty resources are the major constraints. We all talk about clinical, what is really faculty, and what can we do to expand access to nursing education by bringing more faculty into the profession.
A couple of weeks ago, the annual report from the American Association of Colleges of Nursing, and the growth in certain sectors of nursing students is really still going quite strong. PhD prepared nurses is completely flatlined. And this is your future faculty, the future fuel that is going to produce in the next decade more numbers of nurses. And this is an alarming trend. It is, particularly when we realize we need highly educated nurses who can be leaders in healthcare systems. And I am just not hearing enough at the national level of recognizing what a serious issue that this is going to be. Because a lot of the PhD prepared nurses are going to start retiring, and we have a much stronger capacity to educate lower educated nurses than we do the most highly skilled and most highly educated nurses. And so we need desperately, if we could even get a 10% increase in the number of PhD prepared nurses per year, we could be on the right track. But when you see that flat line, absolutely no growth, even though we're preparing more nurses, we can't seem to get them on a track to become faculty someday. And we really need to tackle that problem.
I would say yes.
Maria,
I'm sorry, go ahead.
I'm sorry, Mark, go ahead. I'm interested as well in Maria's thoughts about how, from an institutional standpoint, You have
Yes.
found the relationship with your partner nursing schools and how that experience has changed in part because of COVID. But generally, the issues that both Linda and Mark have raised about slots and the ability to place nurses and get them experience, and how from an institutional standpoint, hospitals are getting to look at that. And I'm going to turn to Polly as well to help the conversation keep going. But Maria?
Sure. Yes. So I think one of the things is for hospitals, we want to have individuals come in as lifelong learners and help them through that journey, whether that's a nurse grow from within program all the way through the master's and PhD levels, having chief nursing officer and training programs like we do. And I think one of the things is it's first about access. When you read that 90,000 qualified applicants could not attend nursing school from the American College Association of Nursing, you think about how can we expand programs? How can we expand entry grants to non-traditional schools like Mark had talked about for those students that are going to be working at the same time as attending school, colleges with amazing reputations and adjacent programs in healthcare to expand and add nursing programs like the alma mater that I went to that added a nursing program and had a renowned physician assistant program. I think all of those solutions where then hospitals can partner to be on-site rotation, clinical offerings, extern programs, all the way up through that PhD can really create the continuum of the pipeline.
I'll jump in here, Sheila, if you're ready. So I'd be interested to know in this question of the nexus between education and practice, how you all are thinking about the transition to practice, both on the education side and on the practice side. We know that large numbers of nurses, even before COVID, were leaving jobs in the first year, and that this question of sort of catching them when they arrive and mentoring and having a soft landing, if you will, is really important. So how are educational institutions thinking about residencies for RNs? I know that residencies for nurse practitioners is a whole separate policy discussion, but just to focus on RNs first, how important are they and what role should the federal government play? Just first to Linda and Mark, and then Maria, I'd be fascinated to hear your thoughts as well.
Thanks for that question, Polly. Because I'm within an academic health center and our students go into very complex care settings, it's quite amazing the difference in where new grads go to work today compared to where they went 20, 25 years ago. And absolutely, they could not make that transition into highly complex care without a residency. That being said, residency programs are very expensive, and nursing care takes place in a lot of different communities and settings. And so the residency program that a huge academic health center, tertiary care center might need might look very different than a residency program in community health or a residency program in a rural hospital serving a less acute population. And so I think we need new models of that transition to care. And we shouldn't make rural hospitals feel somewhat second class because they don't have a robust 12-month residency program. I don't believe every graduating nurse needs a 12-month residency program. I think we're smarter than that. I think we can adapt according to the setting that they're going into. Everyone needs a strong orientation. Everyone needs a mentor. Everyone needs a support system, but it differs according to the care environment they're going into. You know, I often say nursing has changed so dramatically in the last 4 to 5 decades, and we have changed the way we educate nurses very, very little. The content, the required areas, it's still the same. It's the,
Is that, I mean, I wonder whether that isn't part of the problem of retention, is that in a sense, nurses don't really know what practice is going to feel like. And part of that is, I assume, because they don't have as much time in practice settings as I'm sure the educators would like, because it's so difficult to find clinical sites and preceptors. And that's another one of those problem nodes that we need to break open.
Exactly. In addition to not having enough faculty, the second other issue with the pipeline is not having enough clinical placements and preceptors. That clogs the pipeline right at the very beginning. We have now Georgia has a tax credit for precepting. Personally, from my experience, I don't see it's a huge incentive. Don't believe that it is sufficient enough for people to sign on. For that, the people that are signing on are the people that have always done the precept. It doesn't seem to be a huge magnet to bring new preceptors in.
Maria, how are you thinking about the residencies and incentivizing more preceptors in your setting?
Yes, Polly, great question. And one of the things, as we're thinking about pipeline is, especially where I oversee the behavioral health division, subacute, where it's very different from the nursing schools of the past, where someone may have done a 6-month rotation in psych, and that's just not happening. And so we've looked at it as creating our own model of a nurse extern program that right after 1 semester of nursing school, someone can be employed by our hospital, receiving tuition reimbursement and additional subsidy for their education to come and work with us really as a mental health worker, learning what it is like to work in psych while being a nurse extern and attending our UHS nurse residency curriculum. So it's a curriculum that's actually a workplace curriculum for them to be interested in psych, be working, be making money, getting investment in their tuition. Then they're move on in the next year to their nurse extern 2 program. And we try to keep them through that whole continuum where we're subsidizing their education, hopefully for the commitment to work with us in psych afterwards, but then be very much accustomed to what they might face in acute psych or residential treatment facilities, whichever they're choosing. So that's how we're thinking about it, is that we have to really look at employing a nurse before they're ever a nurse, right from the first semester of nursing school.
I want to go back to Mark, but also remind our listeners to send in questions on the chat function. We'd love to hear from you all as well. Mark, how is your university thinking about the transition to practice and the problem of lack of clinical settings for preceptor experiences?
I think building on what Linda was talking about, we really haven't made giant leaps in how we educate nurses. And one size does not fit all in practice. Everything from community health to rural health to the acute care settings, the residency experiences need to be varied. And, there's a lot of work that still needs to be done around competency-based education to make sure we're getting them where they need to be. And there's new research that needs to be done in those areas to advance that. And I really think some of the answers to us really bending the curve on the shortage is going to be, how do we think differently about educating our nurses in those experiences around clinical settings? I think all nursing schools in the US, or vast majority, we've really advanced these past 2 decades with advanced patient simulation. A product of what the military brought us out of Desert Storm. We've really made great strides in how to use simulation to supplement and complement our clinical face-to-face experiences. And I think that same philosophy and strategies need to be expanded in a transition to practice. I think we need to think differently about how we do certain things, where we are tied to tradition. And I think it's an opportunity for us. Adversity yields opportunity. And I think this is where we need to step up as educators to think about that opportunity.
Although I worry that the simulation is kind of getting away from some of the everyday pressures that people face when they actually do start a job. I mean, you don't have a patient slapping you in the face when you're doing simulation. And, those are the things that happen in real life and make the job so hard. So it's a trade-off, I guess. You can certainly do more and more, but it may not be the same results. Does anyone do any tracking of graduates to see what the percent are that immediately leave their job in the first year, and sort of tie it back to educational interventions that might help people be more prepared? Has there been any sort of research on your part that kind of understands whether one approach is better than another approach in terms of the outcomes measured in this case, just in the short-term retention in a place of work? Or is there a sense that it really isn't, it isn't dependent on the education? It's really more dependent on the workplace exclusively.
So at Emory now, we have a kind of a natural experiment going on where 100 of our undergraduate, or I should call them pre-licensure students, actually participate in a program called In Emory, which is very similar to what Maria was describing, where they start building their connections with the choice of where they want to work early. They get expanded opportunities to work with mentors. They get Emory-centric rotations. They are made to feel a part of that community before they even graduate. And then we have our other students that many do rotate through Emory, but they also go through many other hospitals. And this is just to be able to measure empirically if that is a retention driver, that if you build a positive connection early on, you will retain a student into your workforce. But we need those studies. They are critically important. And studies comparing graduates who go through residency programs versus graduates that don't. Does that really?
I gather that, there's pretty strong research on that question. We do know that residencies lead to higher retention.
And then also the impact of either loan repayment or educational assistance, actually demonstrating through an economic lens, if you really, the cost you save in turnover pays for those enhanced educational benefits that you give nurses. We need studies, but to this point, I've been rather disappointed with the evidence that we do have. And so for instance, when we had the demonstration project for funding, CMS funding for nurse practitioner training and giving hospitals the incentives to provide preceptors, the evidence was clearly there. The evaluation report showed the effectiveness of that demonstration project, but getting the federal government to adopt that is very difficult. Getting back to PhD prepared nurses, Robert Wood Johnson had a demonstration project on 3-year PhD programs. Phenomenal outcomes. No one's adopting those models.
Yeah. So these are options that are shovel ready.
I
know. we know it would help.
Yes.
How do we really package this evidence and say what's stopping us from expanding? Thank God Title VIII, the evidence is there, and Title VIII funding, Title VII funding is expanding, but that does not solve many of the staffing problems in hospital systems.
No, and there's going to be a lot of money coming down the pipeline for nursing education, I'm sure. So the question is how to best use it. Right. What's the most effective? And go ahead, Maria. Yeah.
Yes, I think that's where, Linda brought up a good point in talking about our nurse extern program and getting them right from the first semester, right? And they'll stay with us and you're providing student loan repayment and tuition reimbursement. But these are the investments that hospitals are making, where when hospitals are asking for, looking at reimbursements, payers, improving that. Well, these are the things that we're investing in. We're even investing in, for example, post-hire surveying. So we understand somebody's experience after 7 days, after 30 days of onboarding. Do they need to go for some more retraining with their preceptor in more detail after 90 days? So these kind of investments for hospitals are the things that are not quantified, where folks may not see. This is why hospitals are asking for some greater reimbursements here, because we want to be subsidizing these types of programs that we know are effective in keeping nurses engaged and retained.
Yeah. I'm going to throw out one slightly provocative question before we turn to the audience, and we have some good questions coming in, so I want to leave time for that. But on this question of the role of frontline nurses in making decisions about workflow, about scheduling, about staffing levels, to what extent are the educators on this panel and the employer on this panel thinking about the need to help administrators understand how important the nurse's voice is in decisions? And how do you prepare people to be at the table and sort of demand a voice, and to I often hear about programs that teach business to nurses, and so that they can be at the table. And then I think, well, why don't the business people have to take courses about being a nurse? Couldn't you, if you don't speak each other's language, it's a problem both ways. So how are you thinking about sort of preparing nurses to be strong in their conversations with the administrators? And how is the hospital thinking about helping that dialogue happen in a way that's more productive? Mark, let's start with you, since we've been picking on Linda and Maria a lot.
No, thanks, Polly. I think in our institution, it really starts around policy and making sure that those students are aware of the policies that are affecting their practice, and the engagement and involvement in helping them advocate for themselves. It's not just advocating for their profession or their patient. It's learning that self-awareness to advocate for themselves. And that is so important in this day and age, that they understand that they have a voice, their voice is powerful. And it's like, how do they utilize that? That is a big part of our educational process. And I think that voice is going to help them in their practice.
Maria, on
Yes.
the employer side, how do you think about this?
Yeah, so I think it's really important. This is one of the things that we talk about all the time with our administrators, many of whom actually in the behavioral health space came up as nursing individuals, chief nursing officers, and the connection with their nurse teams and the focus groups that they hold, some of the ability for autonomy when it comes to things like you're talking about, the scheduling, the work-life balance, the building of that, what that looks like, the nursing teams and the team care, and what tools and resources are necessary for them to be able to practice at the top of their license. And so these are discussions that we put as part of our training for any administrator going into the C-suite, and that the leadership team is constantly having these focus group meetings with their nursing teams. So it's a big focus for us as far as the voice of the nurse, the purposeful rounding, walk a mile in the shoes of all of our direct care professionals, not just our nurses. Our mental health techs in the behavioral space have a huge impact on our patient care. And therefore we have to understand and do that walk a mile, and our administrators do that.
That's terrific.
The magnet designation is another critically important tool if a hospital can afford those resources to go for magnet status. Again, it's a high bar for many smaller hospitals, and maybe we need a different type of magnet that could be for coalitions of smaller hospitals. But we begin early in the education of our students to teach them the magnet difference, so they begin to understand the power of voice and governance. But I'll be really frank with you, we still have a long way to go to get nursing leadership at the highest level in health system governance. It is still very much dominated by medicine, business, and law. And nursing, if there's one nurse on the board, that's viewed as a huge achievement, when really, when you consider the size of the workforce, it's still nursing is very underrepresented. And the lack of nursing expertise on boards who really understand operations and workforce issues and educational pipeline issues and educational preparation it's striking. It's
yeah. Well, with that powerful statement, I'm going to turn to the questions coming from the audience. So the first one is, how much are hospitals and nursing schools looking to the federal government to take action and enact policies? And how much do they want to stay independent of new federal rules and create their own? I guess it depends on what those rules are.
Yes, certainly a balance to strike there. But I think that, there are some policies that can help. I think you mentioned a stat of, 60% of individuals coming out of the West are immediately employed after graduation, coming out of RN schools. I think there's certain things where you look at even nurse licensure compact states. Well, many of those states, or a large portion, California, Nevada, Oregon, Washington State, they're not nurse license compact states yet. I think of the ones I mentioned, only Washington has maybe even legislation that they're talking about or pending. And so I think there's certain things that, that could assist. And I think even during the pandemic, when there were some states that, looked at the LPN scope of practice and our ability to look at LPN to RN as we're trying to grow folks, the LPNs are a critical role, and RNs are very happy as we've supplemented staffing with LPNs and the pieces of nursing assessments that they can do and assist with to take burdens off of nurses. So from an employer perspective, I think there's a lot that we're trying to do, but at the same time, there's policies that could help us do it even better.
I believe deeply that nursing is a public good, and the production of a sufficient number of nurses to care for our population is a public good. I don't believe healthcare in the environment, every environment that delivers healthcare, needs to be joined at the hip with government, although we certainly are with Medicare. We're teasing, we're fooling ourselves if we don't think that everything we do is tied to government. I think for the production of nurses right now, to really get our country where it needs to be, there needs to be investment at the national and the state level. And these state by state differences in licensure and scope of practice do nothing but hurt us in today's world.
Well, let me throw the next question to Mark, because it sounds like you're doing a lot of work with employers in Kentucky. So the question is whether there's an ideal partnership between hospitals and schools of nursing, and if so, what that sweet spot is, and should there be a policy option available to move that model forward?
Very passionate about this element here, Polly. There's a great framework for creating these practice partnerships. It's called, through the AACN, it's the Academic Practice Partnership Model, which is really foundational groundwork for how a lot of institutions can work with an academic practice partner. We are fortunate that we are part of the HCA healthcare system. So we have our academic practice partnerships extend throughout the Southeast and the West. But these partnerships, I think, are so integral to many of the questions that we talked about. Coming post-pandemic, working closer with your academic practice partnership has never been more important than it is today. And that seamless transition of information and data going back and forth, I believe we need as educators, but we also need to understand their needs as well. And I think we are at that crossroads, Polly, that these conversations are happening more frequently than I've ever seen in my career.
Yeah.
So I just think it's a great opportunity for those that aren't participating to really step up here on both sides.
That's great. So the last question, Maria, I'm going to throw to you, and hopefully it's on a more sort of a positive note. I think Mark's comment was also quite positive, but there's a question about how hospitals are investing differently now in nurses' mental health to make nurses feel valued, safe, and ultimately want to stay in the profession.
Absolutely. Well, I think, first of all, sometimes caregivers are the most reluctant to seek self-care. And so I think first and foremost, there was a lot of things that happened at COVID that were concerns that led to burnout. There was childcare, there was the COVID, in the workplace, the escalating patient acuity that was occurring. And so we thought differently about it in a number of ways. We have to look at reducing burnout in the workplace with revitalization and recharge opportunities, whether that be private spaces for our nurses and our direct care professionals to really recharge during the workplace at any time that they needed to, and being able to alleviate for that care. Certainly a more robust employee assistance program that extends to all areas of their life. So work-life care, legal financial care, care for well-being, whether it be in person, mobile, whichever way that someone needs to access care that is readily at their fingertips. I think there was also a lot of different things that we did with a more team approach to nursing, really looking at what are the supports that a nurse is telling us would make for a more enjoyable workday. And what are those? Whether it's technology, tools, different staffing models. So I think that we really looked at that. And then also, implementing a feedback mechanism that is real time, not just a feedback mechanism like your engagement survey, but real time surveying. So we understand, what our employees, what drives their engagement, what drives their satisfaction, so we can leverage that even greater.
Mm-hmm. That makes a lot of sense. Listen. Feedback,
That's
feedback,
right.
feedback.
Yes, exactly right. And then make sure you're making some of those changes really concrete, after you get that feedback.
Yeah. Well, this has been a terrific conversation about a pretty complex issue. And I've really enjoyed getting to know the three panelists, and I appreciate the opportunity to participate. I'm going to hand it back to our fearless leader, Bill Hoagland, to close us out.
Thank you very much, Polly, Linda, Maria. This has been a real valuable set of information provided to us. Thank you, Mark. I want to just say that I'm a novice in this area, but I take away from this discussion that there's still a great deal of interest in nursing out there. That's good. But the funnel, if I can describe it that way, of the applicants coming in and the production coming out of the funnel is limited by its ability to produce those nurses and is restricted in large. And I'm taking away, this is just my takeaway, by a lack of in the faculty area, particularly what was mentioned in terms of the flat line on the PhD nurses and the training nurses is part of that. Also, the comment that Polly made at the outset bothers me. It was a nice, I'm glad, Maria, you made your comments here at the end, because I was concerned about this comment about moral injury. And maybe the nurses feel that they are not doing the job for which their profession, what they were trained, and maybe they feel that it's not what they expected or what they want, and maybe that has something to do with the organizational culture. But I think I can say fairly confidently that the people they serve, the patients, the families out there, they highly respect this profession, and it's one in which they should recognize that they are one of the most respected professions out there. So thank you again, and thank you, Chip and the Federation of American Hospitals, for your support of this event. We will take this information, compile it, we'll continue to work with it. We hope that we can develop some recommendations that can be seriously considered going forward. Thank you, and have a good day, and remain safe, everybody.